end of the inaugural session. We are starting the next session. May I request all the distinguished panel, please join us. A group photograph? Okay, fast. Now the next session moderator is already here, Anthony Prasad, from the partner from Deloitte. I request the distinguished panelists, Dr. Sumitra, Medical Director, Holy Family Hospital, please join us. Dr. Vishal Arora, Chief of Business Transformation and Operational Excellence, Artemis Hospital. Mr. Amit, the founder and CEO, Logic Boots Private Limited, and Dr. Reshmi Gupta, is she here? Yeah, Dr. Reshmi Gupta, Managing Director, Felix Hospital. Ladies and gentlemen, put hands together to welcoming all the distinguished panelists. May I request all the panelists, please take your seats, sir. Arvind sir, hope you are joining us for this panel. लंच साथ में करके जाएंगे प्लीज अच्छा ठीक है डिनर करने आएंगे गुड आई विल वेट फॉर यू सो वंस अगेन आई वुड लाइक टू इंट्रोड्यूस द पैनल इज moderated by Mr. Anthony Prasad, the partner of Deloitte India, Dr. Reshmi Gupta, Managing Director, Felix Hospital, Dr. Sumitra, Medical Director, Holy Family Hospital, Dr. Vishal Arora, Chief of Business Transformation and Operational Excellence, Artemis, and Mr. Amit Singh, the founder and CEO, Logic Boots Private Limited. Anthony, over to you.
Thanks, Shashi, for this. We had a exciting inaugural session which got concluded, and the type of insights that came out and the interventions that we are looking at for the industry is much promising, and I think it sets the path for this conversation as well. Maybe I'll give a quick brief, taking points from the previous session. A lot of us spoke about AI and advanced analytics and how it's going to have a big impact on the healthcare ecosystem. Ultimately, when we talk about all this, it's primarily to achieve 3-4 obvious goals, right? We talk about improved quality of care, affordable care, and accessible care. And most important is when we talk about affordability, how all this can be at a reduced cost, right? And technology is playing an important role. When I walked out into the Delhi airport today, and imagine 15-20 years before, when we had to get into an airport, look at the airline ticket that we had. It was like a passbook, or like a checkbook that we had, right? And later it changed into a piece of paper, and then post that it changed. You don't need a paper, you can just show it on your mobile phone. And now you don't even need to show your mobile phone, you just walk through Digi-Yatra, right? It recognizes your face. So that's the shift that we are seeing in technology and how it's changing the way we as individuals function in our day-to-day life. And that's the big, and how are we as a country adopting to these changes? And also we spoke about 5G, Mr. Robert spoke about it. But the biggest impact that we need to also be aware is, because of 5G, the consumer of the future is also going to be different, right? He is going to demand a lot of outcomes, right? AI-based outcomes for healthcare. He's going to exert pressure on the system. And with that segue, I thought maybe Dr. Reshmi, I will start the opening question with you. Where do you think AI is going to play a big impact on the patient journey, right? Right from diagnosis, or rather from preventive health to diagnosis, treatment, and then, post-treatment. What's your views on that?
Actually, the AI has come so much into the system that everybody is aware of it, it is going to help us. But the major gap is there because we have worked on AI, we have worked on the systems, but we have worked very little on the data security and privacy. That is the big challenge. Even when the hospitals are using it, there is a challenge of data security and the patient privacy, which is a big challenge that we are not using it as at par as we should have. So now the people are aware, now everybody is like, they don't need any hard copy of reports, they don't need, everything is on apps. So from the very beginning to the very end, it is working very good. So for the HIS, the Hospital Information System, the patient's journey from the admission to the hospital to the discharge, everything is there. And the most important is the patient is quite aware of the things, and we can track very well the whole journey of the diseases, especially if we talk about the chronic diseases. So it will be quite easy to map the things, because people often forget what treatment they have taken 2 years back, what kind of surgeries they have taken few years back. They don't have the document, they have shifted somewhere or they got transferred to some place or the other. By AI and by this all digitalization, it will be very easy to improve the quality of services we can provide to the patient.
Got it. Great. I think the point that you made on quality and when we spoke about accessibility, maybe Dr. Sumit, I would wanted your views on this, because see, we spoke about, let's say, a lot of information which is available. Today, I mean, 2 weeks back, I was speaking to another hospital, and they are looking at the moment you send a picture of your retina, they are able to predict whether you have a diabetic retinopathy or, whether you'll be impacted by that or not. So, where it also reduces the inflow of OPD patients also. And the most important thing is, how is this shift that how are you prepared for this shift, and what are you doing it from your hospital perspective?
Yeah. So before I go on to that, just adding to what Dr. Gupta said, I'm still an intensivist more than an administrator, health administrator. So as an intensivist, I see critically ill patients, and I've done that for more than 25 years. So I'm just giving you the history, the reason being that I look at healthcare a little differently. And we as intensivists have used technology as doctors, intense technology for a long time. Ventilators, monitors, huge amounts of data. So how would AI help us in that? One is that integrating all that data to give us, in a nutshell, a lot of the conditional issues that are there with the patient, which visualization of that sometimes is difficult. It would help us in that. Where it would help an intensivist or a clinician in many ways in terms of focusing on certain kinds of research, which was spoken about, what is called now precision medicine or personalized medicine. I don't like the word personalized medicine because it puts individuals in silos, maybe more precision medicine, is the fact that huge data analytics is able to identify subphenotypes of patients who will require what kind of therapy. Those are the great advantages of AI. AI will be part of medical care, there is no doubt about it. Having said that, I have another introduction I want to, is that, when I was growing up, I was told never be seduced. My father told me never get seduced easily. And my partner in life also tells me that, don't get seduced too easily. And I'm never easily seduced by technology. Technology I use regularly, daily, intensively for many years, okay? So what are my anxieties about it? So the point is, when we are looking at artificial intelligence in healthcare, the importance is, who are we looking at? What are we trying to benefit, and who are we trying to benefit? Finally, it is the patient and the healthcare provider, the interaction between them. That is the focus of healthcare delivery, I think. It is not, so what has data and research suggested to us? Has it helped improve outcomes? No. That is the productivity paradox of AI and digital health till now. It has not improved outcomes. What it has done has improved billing, it has improved data collection, it has improved diagnostics, but not outcomes. Until it improves outcomes, the question, the role of it is we have to see how we can improve outcomes. So that's the question. So for me, the focus is the patient. Are we involving patients in making the, the digital health with technology which we are developing? That's an important factor. The reason I'm saying is, there's an example from Kerala, palliative healthcare. One of the best palliative healthcare at one of the cheapest rates in the world, at the least amount of cost in the world, is from Kerala. What did they do? How did they gather their data? They always involved the patients involved who were at the receiving end of it, that what they need. Are we doing it with digital technology, right? So that has to be the focus. Finally, it is not profit. I believe that healthcare should not be for profit. If you see the best healthcare delivery systems in the world, which are the best healthcare delivery? If you look at the outcomes of healthcare, these are good public healthcare systems. If you look at OECD countries, the best healthcare is provided by public health systems, not by the United States, which has an over-privatized healthcare system like ours. It is also financially unviable for the US. It spends 17% of its GDP on health, with much poorer outcomes than any OECD country, compared to 8.5 to 9% of GDP spent by other developed countries. If you look at LMIC countries where we are from, which are the countries which have done good and well in healthcare delivery and outcomes? Sri Lanka, Vietnam, Thailand. What is their spending on healthcare? You know, when we are focusing on digital healthcare and technology, we are forgetting the fact that healthcare requires investments. It requires people on the ground. I volunteer at a hospital in Chhattisgarh, 70-bed hospital, do fantastic work there. They do fantastic work. When I go there, when I help them in the ICU, what did I find out? I found out that when I'm there, it helps. How does it, with the digital technology, when I connect with them from here to a certain extent, it helps. But without healthcare workers on the ground, it is of zero value. Because why is that? There are many studies which show that. The touch of the healthcare worker is as important as the algorithms that we provide for better health. Without a good nurse, so when Holy Family, I mean, I'm not trying to brag here, is considered that it's a very good healthcare delivery system, what is the most important thing the patients say? They say, well, doctors are good maybe. The nursing care is incredible. And I say that not because I'm going to, I mean, for the nurses here, it is about the human touch. All these elements have to be considered in digital health and AI before we go forward. Sorry, I've taken a lot of time because I wanted to, as they call, disrupt. That's a favorite word now. So disrupt things, the excitement of technology. We have to question that excitement, not get completely seduced by it.
Thanks, Dr. Sumit. In fact, in my personal view, when we say AI in healthcare, I don't call it artificial intelligence. I would like to call it augmented intelligence. You augment your intelligence to take better decisions, right? So that's exactly what we're looking at. And obviously, you spoke about outcomes. Yes, while there are benefits in terms of how can you reduce diagnosis time and put your patient into the treatment cycle much faster, that's something which we are also looking at. As we discuss this, we also have seen that how can we do more with less, right? Because as a country, there are infrastructure challenges, but we still were able to rise up to the occasion, and COVID is a very big example for all of us, which means a lot of efficiencies that can come up in the healthcare ecosystem as well, right? While one is care delivery, but as a hospital, as a unit, there are, how do we build efficiencies using AI? And maybe this is where, Vishal, I thought I will like to take your thoughts. You know, you focus on business transformation at Artemis. what are ways that, dimensions, while we can talk about cost, but more important aspects like reducing patient waiting time, or, how there are a lot of movable assets in an hospital, how AI can help manage all of that. What's your view from an operational efficiencies point of view?
Sure, thank you, Anthony. So, AI in healthcare is something which is the need of the hour. So, there are no second thoughts to it. If you see from an administrator perspective, there would be 4 angles to it. One angle, Dr. Sumit has already covered, so that's the clinical angle. The 3 other angles which we largely speak about, one is the patient perspective, right? We're coming in, a patient coming into a hospital, how can technology help in? Second angle, I'll be speaking about all the 3 angles, maybe 5 minutes I'll take. Second angle is on the cost effectiveness. So how can technology help hospital become more cost effective? And third is how can it help increase the revenue? So these are the 3 angles. Now, touching on to each of them point by point. So first one would be on the patient perspective. So there are stats which says roughly around 15% of the patients who spend more than an hour in the waiting of a OPD tend to change their healthcare provider. So that's where it's a potential revenue loss for the hospital. There is a lot of load on the hospital, specifically coming from the front office where there are queued up. Generally, OPD hours are limited, right? So typically, hospital tend to do 10 to 3 is their typical peak OPD hours, where most of the OPDs would be queued up. The entire system is overloaded. That's where technology would come into play again. So using augmented intelligence from the point starting from the scratch, maybe where a patient can, as Dr. Bali was mentioning in the morning, how many of us would use app, right? So if a patient can directly book on an app, come into the queue, maybe he lands up in the OPD, a doctor prescribes on the EMR, the investigations and the pharmacy for the particular patient. The patient automatically gets a WhatsApp, right? These are the investigations booked for, the doctor has advised for you, this is the amount, click to pay. If you want to deselect anyone, deselect and just go ahead and pay. You automatically land up in the sample collection center where your queue is already getting displayed. You've already paid up. So you bypass the entire system, going back to the long queue of reception, checking what the prices are. Would you want to get the test selected or not? Eventually end up in the sample collection, getting it collected, and your report is displayed on your WhatsApp as soon as it is ready. Right? So this, or from a pharmacy perspective, right? So your pharmacy is already ready in the pharmacy. You just go and collect it, pay it, and move on. So life can be that simple from an operations perspective when we talk about using augmentation in the real life. When we talk about avenues like a cost optimization, so I see many nurses from Holy Family attending this. So again, a stat, I'll augment my statement by a stat. More than 10 hours a week of the healthcare administrator, 50% of the healthcare employees, healthcare workforce goes into the clerical works. How can we reduce that leveraging technology and effectively make use of that in delivering patient care? The same stat also says more than another 20% is the chunk who spend more than 20 hours a week, which is 50% of the time in the clerical work. There is where technology comes into play. I'll give you certain case studies. Maybe an example with a simple use case of a RPA, robotic process automation, where as of now, if I want to do a simple TPA reconciliation for any hospital, that's a pain area, against which patient the payment has come up, right? What is the deduction? Maybe more than, for a hospital of our size, there is a team of 3 people who are doing this job day in and day out, which is a simple thing where the technology can pick up my bank statement, what the payment has come in, open the account of the TPA against which it has been settled, what was the due, what is the TDS amount, what is the balance amount, and what the deduction is against. As of now, this for most of us would be a manual activity. Another use case on same thing on the CGHS ESI empanelments. Now we use the portal to update the bills, the exact history of the patient. That is again a simple manual activity which can be easily automated and lives of everyone becomes easy. Simple paradigm, rostering for a nursing. So as of now, how typically we tend to do nursing rostering, right? So we have a bed count, say particular floor would have 10 beds, we apply 5:1 is the ratio, we will stack 2 nurses per shift for the particular day throughout 365. But no one can actually predict. That's where predictive analytics would come into play, and using a dynamic rostering kind of a system, I can use AI, train my tech to leverage how I can stack my nurses across the year. It becomes more of a dynamic roasting wherein morning a WhatsApp would be given to a nurse, your shift is today at this particular floor, at this particular area, you will be seeing patient number this to this. That's where we can at least cut down our 5-7% of our cost, which eventually gets passed on to the patients. None of the hospitals, most of the hospitals are sub 20 kind of a EBITDA margin which they enjoy, barring a few who are northwards of 20%. So that's where the cost pressure on the hospital is there, where they can leverage technology and cut down on their cost as well. So these are certain examples where, yeah.
Sure. Vishal, not to put you on the spot, but we discussed this while there are operational efficiencies. Are we transferring this back to the patient?
So eventually, Anthony, we discussed this in the morning as well. So how would it get transferred? Eventually, every year hospital does a price increase to meet their inflation cost, right? If I am enjoying my EBITDA margins and I am at a healthy EBITDA margin, I would not tend to pass on that to my cash patients, right? I'll tend to, rather than doing a 5% price escalation, I'll settle for 3. That's a pseudo way on passing on these benefits to the patient, right? And that's how somehow eventually I told you in the morning as well. So hospitals cross-subsidize. The amount of CGHS and the panel business we have been doing, the eventual burden is passed on to the cash patient. So getting in the leverage of operational efficiencies, leveraging technology, the burden on the cash patients would go down lesser.
Sure. Just to flip this question back to you, Dr. Sumit, is Vishal spoke about how we can use technology to improve efficiency in hospital management. Now, if I take this further to the physician, right? A lot of times the physician spends on writing the case history and stuff, and then you have technologies on voice-based recognitions, auto dictation, and all of that. Where do you think today physicians are in the maturity curve for adopting technologies? Right. And also, when I started this, we spoke about how the consumer of the future is going to be more tech savvy, and he would prefer a physician who's also tech savvy, right? So, in your view, how is a physician of the future going to look like? A physician with AI or a physician without AI? What's the preference going to be like?
So, see, there is no doubt that we, as physicians, as nurses, we have to be part of the whole process of adopting AI. There's no doubt, right? Having said that, 2-3 things. As I said initially, what is the intent of the delivery of care? Second is you gave very good statistics about about governance of healthcare, but also realize that 30% hands-off time by nurses and doctors because of electronic medical records. Right. Actually, you have to increase your staffing of nurses if you want the same amount of hands-on time on the patients in the IPD if you use electronic medical records. I'm not talking about the lab data, the radiological data, where it will be very, very useful, but I'm looking at writing the notes, etc. So when we look ahead, as you said, probably voice recognition, doing the notes like that would be very, very useful, because one of the biggest problems of non-adoption of EMR in many places by physicians and nurses is the time spent of the patient. In the OPD, so there was this major study in New York health system. They have adopted digital health. Huge amounts of money they have paid in, more than $3 billion into the, and they found that so many physicians said, the patients come and say, he's looking at the computer, not at me. Okay? So you have to realize healthcare is not like any other industry. That individual connect with the patient is as important for the physician as the use of technology. So that element has to be always integrated into that. And that is what, I'm sorry to say, please don't take it personally, that IT people do not take into consideration. And they are for me, sometimes if an IT person's relative is admitted to the ICU, it is the most difficult for me to explain to them, because they think life is an algorithm and patient is an algorithm which can be controlled, which is not true. As Mr. Ravi said, that patient is millions and trillions of cells, and we understand only certain elements of it. And a lot of it, our clinical judgment, what does it mean? Clinical judgment is not in the air. Clinical judgment is dependent on the information we get, but also the experience of a visual look at that patient and the touch of the patient, the feel of the patient. If you don't use a stethoscope, you may use an ultrasound probe, but you need to see, touch. So all these elements are very, very important, and that remains. The other is, as I said, intent. Is it for profit? So Mr. Ravi also spoke about many of the things that have been implemented in Tamil Nadu. He was focusing on Tamil Nadu. Why is it that? Kerala, Tamil Nadu, two different, completely different from the rest of the country. Why? The intent and the governance is totally different. And that brings us to the question that what you put about, data security. What is this information is going to be used? And I don't mean only data stealing. I mean surveillance by governments. You can have a Putin or a Chinese government which can have so much surveillance. DG Yatra, it's a mechanism of surveillance too. So all these elements have to be looked at, and as I said, I don't get easily seduced just by technology.
Thanks for putting that, Dr. Sumit. I always like these debative conversations, but just to give you another perspective is, technology can reduce the burden on the physician, and so that he spends more time with the patient, right? Right?
It's possible, but not being done yet.
Yeah, that's the intent.
Actually, this is all about a balance.
Right.
Yeah, everybody is very happy कि the documentation part or the other part, if AI or with the help of digitalization, the time can be spared, that can be consumed with the patient.
Absolutely.
That can be consumed for the interactions.
Actually hasn't happened. Actually, it has taken people's hands off patients more.
Yeah.
Actually, Denmark and Sweden, Denmark has gone off EMR as a country. Sweden is probably going to go off EMR because that's what they found. Having said that, again, analysis, Deloitte is one of the big four, so I think I can't remember, either Ernst & Young or PwC did an analysis. The only jobs which are going to increase in the next 25 years is caregiving jobs. For there, you need people's touch. Repeatedly, I'm reminding, because caregiving jobs are going to increase, while other jobs, AI will take away many of the jobs that we do, many of the scud work is done, but caregiving jobs will increase because the human touch is very, very important.
So I'll just add what Dr. Sumit has been saying. So Dr. Sumit, as an administrator, we completely echo what you have been saying. So, and I'm tempted to say, so 100% echo what you have said, that technology cannot replace clinicians and the personalized touch has to be there. And what Dr. Ashmi said, so where technology comes in and creates a balance, maybe in the OPD, I'll give you an example where it is a voice to text kind of a situation, or maybe a simple stylus and doctor scribbling on a iPad and the handwriting gets read and it is automated into a digital prescription to the patient, right? So that's the balance what we want to create, and that's the era what we are looking at. There have been hits, misses, and we are learning, right? So eventually that's where technology and sympathy and medical care gets balanced out. That's the future what we would look at.
Absolutely right. You put it right, Vishal. And as we talk about technology, obviously there is a lot of policy interventions. Yes. And then it also, like what you said, there is some people get seduced by technology, and you feel more startups also coming in. With that perspective, Amit, I just want to flip it to you. Where do you think the startup ecosystem in health tech is currently now? And also, if you look at today's adoption rate, you have digital pharmacies, diagnostic services, at least even for, like Vishal spoke about, app-based booking and all of that. Where do you think are some of these sub-segments in the healthcare ecosystem where it is a big play for startups? And what are some of the challenges that we face from a policy perspective that you think we should look into?
Thank you, Anton, for this wonderful question. I would like to answer same. Jai Hind, everyone. First of all, as a startup, we are working on manufacturing of such medical devices which is more advanced than what till now is being imported from other countries. As far as I am concerned, I'll talk about our products and what challenges we have faced in the past. We have been working into the innovation part since 2013. But the ecosystem now, what we are getting, was not available during that time. From funding to all, everything. Like Logic Boots is being nurtured under Ministry of Electronics and IT, STPI, and also incubated at IIT Roorkee. Our first product is the device which is the best friend of doctors, a stethoscope. We are working on that, and like as sir said, it's a AI-based stethoscope. And it can not only just listen the murmurs, the patient sitting in Chennai and the doctor sitting in Delhi can listen the real-time murmurs of that patient. First. Second one is, apart from that, we are also giving the ECGs on the cloud app. Apart from that, the most important work, which is also a dream project, like it will detect the heart and lungs diseases at the moment in the real time, and the early detection of heart and lungs diseases is what we are working on. And this is the first project which is for which the preclinical trials are going on at AMTs at Vizag. Apart from that, another project which we are working on is nanotechnologies. Like we are working on nanobots which can destroy the cancer tumors by blocking the blood supply towards the tumors. So these are the two projects in the healthcare industry we are working on. As far as government is concerned, like I personally belong to a lower middle class family. My father was working in the Indian Army. I left the government job and just to pursue my dreams and do something for the country, at least in the innovation part in the health tech industry. And till now, we have seen like most of the devices are being imported from the other countries. And now we are capable to manufacture more advanced version of that. And that's what we are doing currently. So, and the government is helping like from being providing the mentorship to connecting to doctors. Like till now, engineers and doctors are like, they are moving the another way. But now we can directly, we are incubated at Medtech SGPGI, we can approach to the doctors, we can take the time, even from AMTZ, even IIT Roorkee is helping to connect with the biomedical colleges at Chandigarh to get the data sets and all. So it's a combination is what we are looking for. And that's helping us a lot to find the like, we can do the electronics and the software part. But the prime work is of the doctors, that has to be told by the doctors. And apart from that, government is providing a lot of funding. And वो कहते थे ना पहले कि पैसा नहीं है तो business कैसे करो? तो वो चीज़ें ख़त्म हो चुकी है अब. Now we have the funds. Recently we have received around 15 lakhs from Startup India Seed Fund scheme and through STPI. So we have the fundings, we have the proper ecosystem, we have the government support from preclinical trials. Like recently for the 3 times we have done meetings with Medtech Mitra. It's a part of ICMR. And they even ऐसा नहीं होता कि हमें call करना पड़ता और we have to request, they eventually call us. Time to time, every week, that what is the progress, how we are doing, go do the preclinical trials, preparing the dossiers and all, everything. So this kind of ecosystem we are looking for, and it's a perfect time for the startups to innovate.
Absolutely. In fact, Amit, you touched upon a very important point, right? Doctors and engineers working together. Let's say if you do robotics and patients, right? Patients too, absolutely. Have to be part of the absolutely. Let's say robotic surgeries or AI. So just to flip the question, where do you think therefore the big change should happen in our education system itself? Because when you get into a medical degree, then the curriculum also needs to change. You need to be taught robotics, you need to be taught AI, right? Because that's going to be a big shift. So where do you think is the, maybe I'll take Dr. Sumit, your views on this. If you look at it from an education point of view, right. What are the big shifts that you need to expect?
Our health, medical education needs many levels of change. One is obviously understanding technology more, so that when an technology person talks to you, what you expect out of that technology, we are also aware of, right? What we want out of that thing, what are the possibilities? So obviously part of that education has to happen. Also the education which doesn't happen is also our understanding of the economics of health. We don't know. We don't understand, in our education, we are never taught the economics of health. Why should, why should we need to do these investigations? We are taught, and also unfortunately, again, larger hospitals, etc. Our dependence on lot of technology which we can do clinically is also reduced. All these elements, it's also a pressure. All these elements have to be, an example of Ebola was given. Okay, so if you look at the Western African example of Ebola, so what happened in Ebola? Yes, you predicted where it would transmit with technology. Who were the people who could take care? The American doctors who reached there could not take care of the patients. Who took care? The Cuban doctors. Why was that? Because they are trained to do the best they can with the least amount of available technology. So, and they perform the best and save the maximum amount of life. So that is also going to be part of our training. That yes, you learn to use technology, but do the best you can with the least amount of technology. All this also has to be part of our role. Because if we want to approach rural health, right, as I said, I volunteer somewhere. It is not just technology, but your ability to use the least amount of technology to do the best. That capacity also has to be developed.
And therefore the use of technology, Dr. Rashmi, to use very specifically, if you look at the caregiving population in India, right, or if you take physicians, I think we are at around 8 lakh to 10, almost close to 1 million physicians in India, but for a population of 1.3 billion, right, it's a huge gap and therefore technology eventually solves some of our larger problems, right? Obviously, I know we discussed the emotional aspect of it as well, but where do you think the adoption rates for at least at the base level, right, like teleconsultation, telemedicine, are there from an India perspective?
Actually, the whole scenario is to use the technology judiciously. We have to be very cautious and we have to be acceptable to this, because the scenario is like 35% of the population is there in the urban areas and 80% of the medical health is there in the urban areas. So we have to actually realize the real scenario and act accordingly. Because to reach to the underprivileged areas, to reach the rural areas, we have to be open to the use of this technology, use of telemedicine, because it is not possible. It will take a huge, rather a long way to reach all the population if we talk about the human touch. So we have to be very practical about what actually we need to do and what actually the telemedicine and the AI and the digitalization should be used. To serve the rural areas, definitely we have to be dependent on the telemedicine, and we should make system and data analytics and rather data privacy and education of the rural population. First we have to make them acceptable to telemedicine. So we have to be very practical and very receptive to the things. Because we cannot say this is practical and this is not practical and this can be done and this cannot be done. We have to see it into the real scenario, what actually is the scenario. And in Indian scenario, we have to be adaptive and we have to accept this truth that we should move to the technology and for urban population and to cover the health to all. This is not easy to say that this can be with the human touch. It is not possible. This is the reality. It is not possible. We have to move to the digitalization, we have to move to the telemedicine and make the health approachable to all rather first.
Maybe Dr. Subrat, I'll just come to you. Sure. Just get Vishal's view on this. From a hospital perspective, where do you think you are in terms of reaching to the masses, while you are there in an urban setup? But what are initiatives that you're looking at using technologies to reach in the...
Yes. So, I think I'll echo with what Dr. Rashmi has been saying again. So, I'll give you example, a case study of and Dr. Sumit also mentioned that healthcare workforce will expand. This is the area where 25 years we will see more of people coming in. Now, as the demand increases, the number of, we are already low in terms of the doctor-patient ratio globally, right? So that everyone knows. And overnight nothing can be changed. So we'll be required to use our man-force of the clinicians in such a manner that we are able to, leveraging technology, that we are able to cater to the needs of the people. So that's where I'll give you example of radiologist. Now radiologist is also an era where the radiologists are limited. Smaller hospitals cannot afford a full-time radiologist. That's where the PACS has come into existence, that X-rays are getting reported. Now AI has taken over, where with a confidence level of more than 95%, the X-rays are getting reported automatically by AI. That's beneficial for both the smaller setups and for the bigger setups like us as well, where we do roughly around 200, 300 X-rays a day. The AI reports my X-ray, which are normal, gets passed on, where there is no intervention of a radiologist required. In the order of criticality, it also gets parked, right? So these are the critical X-rays or the critical investigations which the radiologist has to look on the first priority, so that the results are delivered to the clinicians and they get to know this is something which is of high importance and a high priority. So that's where technology would help reaching out to the masses as well as in the ecosystem. Given the count of the clinicians is limited, technology would help us deliver faster and reach out to deliver faster to the patient. So that's where I'll say
It's more to defined by the problem statement and what we want to do.
Correct.
Yeah, Dr.
Just
Smith.
adding to that, I don't think that digital health and caregiving by human touch go against each other. It doesn't go against each other at all. What I mean is that there has to be a healthcare provider, doesn't necessarily have to be a doctor there at the other end. Like as I was saying, that small hospital that I interact with, there has to be a caregiver at that end. Doesn't mean to be a doctor necessarily. You can augment the knowledge from this side to a certain extent. Having said that, most of the good healthcare systems have people on the ground using technology. Which augments, right? The third thing I want to add is this misconception about population. That has been debunked, that we are a large population. China has proved, I don't agree with their model of governance, but China has proved it. Second is the density of population. And second, if you look at our population, it is actually going to shrink soon. Only 3 states have net fertility rates, which will produce more than all states now have net fertility rates where the population is going to shrink. Only 3 states, UP, Bihar and Jharkhand. And in less time than we had been predicted, our population is going to shrink, and it is going to be a disadvantage at that time. So let us not make a bogey out of population. Other countries with higher density of population have done much better than us in health, even among LMIC countries. Look at Vietnam, which has a very high density of population. It's how you deliver care. Kerala is a very densely populated state. It has delivered fantastic healthcare relative to any other state in the country because it is about governance. Niyat kya hai? What you want to do for the people.
Correct.
So it depends on that.
Absolutely. I think well said, Dr. Smith. I think it's what is the intent and how are you prepared for both sides. Yeah. Maybe, we're running short of time. Amit, maybe the last question to you is primarily on, therefore, from a policy perspective, what are if you have to name, what are the 2 big interventions that we would need from a government to enhance adoption of digital in healthcare? What would be your 2 big asks?
Yeah, first of all, till now, whatever support from the government and the policies made for the startups are one of the finest, what I am feeling particularly. And apart from this, 2 things I would like to add on this. First of all, for the fundings, as a startup for the funding part, it takes a lots of time still. Almost sometimes it takes 6 months to 1 year. And the people, the startup founders need to wait till that time. They have 2 options, either wait or do something else. So first of all, this one is what I would like to add on. And apart from that, the trials and all, everything, they are going in pace, like our last talk with the ICMR. They said within 3 months you can finish off with the preclinical trials. So this was earlier, it used to take 1 or 2 years. But now within 3 months we can cope up with that preclinical trials, and then for the real-time on-patient trials and all, everything. So the first one is the funding part. For a startup, it's a fuel. Without that, none of the startups would be able to survive. और सर कितना ही करेगा आदमी घर से लगा के. So we'll be needing some support. To be very frank and practical this time. And second one is even I'm sorry if किसी को बुरा लगे तो, but when we approached the doctors ना, so they were like अभी नहीं, we'll meet 1 week after 1 week. और वो एक तो ये थोड़ा सा यहाँ पे प्रॉब्लम आती है. So I would like to add on कि ये एक सेकेंडरी प्रॉब्लम अब ज़रूरत अभी की है. We are writing the codes, so we'll be needing what medical advice from the doctor itself. मतलब प्रॉब्लम ऐसी हो गई थी सर, वन ऑफ आवर co-founders had married a doctor for the same purpose. Like, he is standing over there.
That is true partnership, I think.
तो अब टेंशन ही खत्म हो गई सर. इवन एट नाइट 2 AM वी यूज टू कॉल हर कि अब ये प्रॉब्लम है, हाउ वी आर गोइंग टू डू इट. सो इस तरह चीज़ें चल रही हैं. तो ये एक थोड़ा सा है ना, वो कहते हैं ना, इंजीनियर्स एंड डॉक्टर्स अब तक हस्बैंड वाइफ की तरफ थे, लड़ेंगे दिन भर, काम साथ ही करना है. बिकॉज विदाउट मेडिकल डिवाइसेस तो डॉक्टर्स के लिए प्रॉब्लम है और हमारे लिए भी. तो वी आर मेकिंग द डिवाइसेस. थोड़ा सा डॉक्टर्स के एंड से आई वुड लाइक टू रिक्वेस्ट कि थोड़ा सा टाइम दिया कीजिए आप लोग. एटलीस्ट दे आर बिजी. 18 घंटे काम करते देखा, बट 5-10 मिनट तो निकाल लिया कीजिए सर, तब तो कुछ बना पाएंगे. अदरवाइज व्हाट वी कैन डू.
Well said, Amit. Maybe I'll open, maybe in the interest of time, maybe we'll take 2 questions from the audience to the panel. Any? There's at the back. Yeah.
So I'll like to ask Mr. Vishal, using any interventions as far as your radiology is concerned, utilization of some new AI tools and all?
So when it comes to our radiology at our hospital, we have been
Yes.
using PACS. So PACS is very commonly deployed across all our hospital network. And in terms of AI, what I spoke about, there are some pilots going on. So which would help us faster report X-rays and stuff like that. That's best what we've been doing as of now.
Great. Thank you very much.
Thank you.
So actually I have a question to Amit sir. So like we are talking about AI, we are talking about healthcare. As a concern
Maybe you need to
raised by,
keep the mic little up.
yeah, as a concern raised by Dr. Rasmi, the main is data security, right? What we are putting, either it could be genomics, metabolomics or proteomics, right? So the analysis what we are doing at the fast level, we are using the AWS, right, which is a US based company. So is there any alternative available in India or supported by Ministry of Information Technology where we can access that server and do the analysis? Because that without that computing services, AI is next to impossible.
Yeah, exactly. As far as cloud server and these kind of things are concerned, there are many options government is providing free of cost to the startups.
Okay.
Starting from Google or AWS, like we have the credit of 5 lakhs till date for the AWS, and apart from that, they are supporting for the next 10 years.
Okay.
So expenditure on the cloud part is almost nil for the startups as of now. We just have to work. पैसे हैं, सर्वर है, टेक्नोलॉजी है, गवर्नमेंट है, डॉक्टर्स भी हैं, तो अब करना खुद को है.
Yeah, actually the problem is I am running like a genomics data startup, okay?
Oh, actually थोड़ा मैं सुन नहीं पा रहा हूँ.
Yeah, actually I am running a startup. We are providing the analytics services.
Okay, great.
But we are impossible to get that information where we can access that file like a server or do the analysis. So
after this discussion,
yeah,
we
will do
meet
that.
and
Maybe,
have a
thanks.
more discussion over that.
Maybe one last question.
Yeah,
from the
one
front.
last question. Yeah.
Hi, Sumit sir. This is Mansoor from PAL Healthcare. So I have a question that dependency of the AI, like we know that the data is not always to be accurate in terms of the diagnosis. So do you think that this is the major threat of the medical diagnosis or for the patient's records for their improvisation of their health, like in the major surgery concerns? Not for the blood test report or the preliminary type of things.
So if I'm get it right, so you're saying, does it help in our diagnostic ability as doctors? No, arriving at a diagnosis, I couldn't get it, sorry.
So what I'm saying that is,
I can hear you, yeah.
yeah, AI is capable, means whatever the data analysis report that AI is given, is that report is capable to cure for to which help the doctor
Right.
to cure their patients.
Okay. Very good question. So what AI has been able to help us with, and this is based on a study on, I don't know if you know about the IBM Watson project, where they used AI and tried to compare it with a clinician. So what was found, and what we see in our practice, is that if AI is used to gather all the diagnostic data, the labs, the radiology, for critical care, the ventilator data, the monitoring data, etc., together, to give a kind of a report which helps us identify the possibilities. But finally, the diagnosis still now, I think, depends still now on the doctor. But when there is more integration of medical disease processes into the AI, which Watson did to a certain extent, there will be a help from that. But see, 25 years down the line, we don't know. As Maynard Keynes and Manmohan Singh said, in the long run, we are all dead. So we don't know what to predict in 25 years. But in the next 10, 15 years, what is possible is that these data integration of our knowledge systems of research, etc., into the diagnostics, etc., will help us arrive at a diagnosis. But the diagnostic ability the diagnostic decision will still be left with the clinicians. It will help. It will surely aid. The possibility of it helping is absolutely there. We are already using it to a certain extent. We always look at Google for so many things, We are already using it, augmented it.
Sure. Thanks. I think this was a very interesting panel, right from we discussed about addressing challenges of our nation to the emotional connect to startup ecosystem and operational efficiencies of an hospital. Thank you very much for my fellow panel members for making this very interesting, and thanks audience for your patient hearing.
Thank you, Anthony. Thank you so much. End of the day, as long as... No, we need to have two more. We need to present a memento. Don't be hurry. We'll give you lunch to everyone. Yes. So, having said that, the affordable healthcare is very important. So, using all this kind of digital or anything, if we can take the ECG from the rural area of Jharkhand or where, end of the day, the affordable healthcare is very important. Having said that, last week I got a call from IIT Mumbai. They started a course for all the healthcare industry, those who are in healthcare industry, for the doctors, for the nurses and everyone. They started same digital healthcare course with UNICEF. So they wanted to come and talk about it, but somehow they could not make it. So this last week they started. It's from IIT Mumbai with UNICEF. They started a special course on digital healthcare. So it's a 6 months and a 1 year course for all the people, those who are working in the healthcare. Sir, thank you very much for chairing this session. I would like to request Commander Bali sir to come and present the memento to the distinguished panelists. First to Anthony, who chaired the session. Anthony Prasad is a partner from Deloitte. Thank you, sir. Now I request Father George to please come on the stage. Thank you, sir. To present a memento to Dr. Reshmi Gupta, Managing Director, Felix Hospital. One hospital to another hospital. Thank you, madam, for sharing your views, and thank you, Father. I request Father Sabu to please come on the stage to present a memento to Dr. Amit. Mr. Amit, founder and CEO, Logic Boot Private Limited. I request Dr. Sumitri to present a memento to Dr. Vishal Arora, your ex-colleague. I hope I am not wrong. So thank you so much. We'll break for the lunch. Oh, sorry. Please. No. I will present the momento to Dr. Sumitra. Because he is part of us. So. Yes, exactly. Thank you so much. We'll break for a lunch. Quick 45 minutes lunch, not 1 hour. And once again, I request those who are there in the stall in the back, please don't talk when the session is on. My humble request with folder dance. It disturbs the entire panel. Thank you so much.